Okay, so hello everyone. So as I already introduced myself, so I'm Dr. Hiba Siddiqui from Dr. Ziauddin University Hospital, Pakistan, and I'm currently working as a senior instructor, oncologist. So today I'm going to present my work that is the prevalence and survival outcomes of L1 CAM positive in endometrial cancer across the molecular subtypes. So that is a systematic review and the meta-analysis I did with my team. So I'm not sure how many among the audience today are the oncologists or familiar with the molecular profiling of the endometrial. So I was talking that I'm not sure how many among the audience today are the oncologists or familiar with the molecular profiling of the endometrial cancer, but I will try to brief in detail. So there is no disclosures related to this presentation, and the outline includes the background, the methodology, the results, and discussion, and at the end, the conclusion and take-home message. So starting with the background, so basically, let me tell you one very important thing that L1 CAM, it is a self-surface glycoprotein. So basically, the main role of this specific glycoprotein is to make the cell invasive and to make it metastasis due to this characteristic. So it has a poor prognosis in endometrial cancers. On the other hand, the endometrial tumors, they are classified according to the PROMIS classification, including the pole mutation, the mismatch repair deficient, no specific molecular profile, P53 wild type, and P53 abnormal. Um, so each subunit shows a very different clinical outcomes, different clinical characteristic features. So we did our meta-analysis for the prevalence of this L1 CAM across these molecular subtype and what is the survival within these groups. Okay, so what is already known on this topic? L1 CAM has a bad prognosis. We already know multiple papers published regarding this. And how this study and what does this study add in our clinical implementation? So basically, number one, this is the first meta-analysis that is going to explore the L1 CAM prevalence across all the subtypes of the endometrial cancers, and also the survival across each of the subtypes in the endometrial cancers. Um, so how how would this study affect practice and how to implement it clinically? Let's explore. Okay, so the aims of this meta-analysis, the primary endpoint was prevalence of L1 CAM prognostic marker across the endometrial molecular subtypes. The secondary endpoints were disease-specific survival in L1 CAM expressed patient within NSMP, MMRD, and P53 abnormal molecular subtypes. One important survival outcomes of the L1 CAM patients were overall survival, progression-free survival, and disease-specific survival in overall all the L1 CAM positive population. So coming towards the methodology, we did the literature search on the PubMed, Embase, and Cochrane library with the keywords of endometrial cancers, L1 CAM, and prevalence, survival. We selected the study, we extracted the data, and we synthesized the data for our the endpoints, and then we made the forest plot and did statistical analysis. So we only included those studies which met the following eligibility criteria, including adult, more than 18 years, and they should have histologically confirmed endometrial carcinoma of any type, like endometrioid cancer, serous cell, or clear cell. So the evaluation of L1 CAM expression using IHC or maybe with the gene expression, both were included. And those studies reporting L1 CAM prevalence across one or more than one molecular subtypes, defined by the PROMIS classification. So we included all these studies in our meta-analysis. So we did the statistical analysis by these two very important software, that is RStudio and Cochrane RevMin. And we used the heterogeneity values for the studies according to the Cochrane Handbook guidance. Coming towards the results, so we included 21 studies after removing the duplicates, the irrelevant title and abstracts. So baseline features of these studies, they were, from 2016 up to 2025, we included all these 21 studies. So if you can see my screen, all of these studies included, they were retrospective. And a majority of the studies, they included endometrioid and non-endometrioid tumors. And also majority of the studies, we can say that they included stage 1 and stage 1 to stage 4 disease. And some of these studies, they report all the subtypes correlation with L1-CAM positive, but some of the studies, they just report only one subtype of the endometrial cancers, like Van Gool just reported regarding the P53 mutation. The Chalia 2021 reported the MMRD only. The Passanen 2021 reported only MMRD and NSMP. So some of them, they report one or more, and some of them report all of these subtypes of endometrial cancer correlation with the L1-CAM. One other important thing is the IHC on the tumor tissue. So L1-CAM identified on IHC on the tumor tissue in all of these studies, and no gene profiling were used. So coming towards the prevalence of L1-CAM across the PROMIS subgroup. Let me tell you one very important thing, that this pole mutation has a very good prognosis in endometrial cancers. So it was very expected result that this L1-CAM prevalence in the pole mutation would definitely be low. And it was found approximately 5% within the pole mutation, followed by the P53 wild type, that in which L1-CAM found to be 26% almost, and NSMP, the L1-CAM prevalence within this group was 30.8. And this was kind of surprising for me, because MMRD has, I cannot say that it has a bad prognosis, because it responds well to the immunotherapy. So we can say that it has good to intermediate prognosis. But despite of that fact, you can see that L1-CAM prevalence was very high within this group. P53 abnormal the findings of L1-CAM prevalence within this group is very consistent, because P53 abnormal, the subtype of the endometrial cancer, has a very aggressive biological behavior. So coming towards the disease-specific survival, so you can see that approximately if within the MMRD group, those patients who were L1-CAM positive within MMRD group of the endometrial cancers, they have 1.75 pooled hazard ratio of these 4 studies. That means that approximately 75% higher hazard risk of the disease-specific death within MMRD group. This has a P significant value and zero heterogeneity among these studies. On the other hand, you can see for the NSMP, it is a high pooled hazard ratio, that is 5.4, and with a very significant p-value. Although the heterogeneity was moderate, but here you can see that this black diamond is showing the pool hazard ratio, which is not reaching up to this no-line effect. So the patients who diagnosed with L1-CAM within NSMP group, they would have 5.4 folds high risk of disease-specific death. And similarly, in the P53 abnormal, you can see and appreciate that this diamond, that is a pool hazard ratio, is somewhat reaching up to the no-line effect. So our p-value is on the border threshold, and the pool pooled hazard ratio is 1.69. That means 1.69 folds higher hazard for the patients diagnosed with L1-CAM positive within P53 abnormal group. So again, the overall survival is, that the two folds higher risk of the death in patients diagnosed with L1-CAM, although the p-value was not much significant as this is reaching up to the no-line effect. But here in the disease-specific survival and the progression-free survival, you can see that clearly the findings are significant the pooled hazard ratio is not reaching up to no line effect in both the survivals, in disease-specific survival as well as in the progression-free survival. With you can say that it has the mild heterogeneity, and this graph has mild to moderate heterogeneity among the studies. So coming towards the discussion, so as we have discussed that the pole mutation has a good prognosis, so definitely we were expecting that the L1-CAM positive patients, they were less in this pole mutation subgroup of the endometrial cancers. On the other hand, the P53 abnormal subgroup has an aggressive behavior, so definitely the L1-CAM prevalence within this group was higher. So this was the paper published in 2016 by Dellinger. The blue graph, this is basically the Kaplan-Meier curve. So this blue line you can see over here is L1-CAM negative patients, and this red line, this is L1-CAM positive patients. So you can see that the 50% survival, the L1-CAM positive patients, more than half of the patients, they were alive even at the end of this study. But you can see that L1-CAM positive patients, their survival is dropping continuously. So there is another meta-analysis by the Gynec, which is very enlightening the stage 1 endometrial cancers only regarding L1-CAM as a poor prognostic factor in stage 1 endometrial cancers. So the findings of this meta-analysis is quite comparable to our study. Their overall survival within L1-CAM positive patients and the disease-free survival in the L1-CAM patients, they were poor. Although the studies that they were included in their meta-analysis, they were not included in our meta-analysis. So coming towards this, Gua et al., this is a very beautiful paper because they explored the role of L1-CAM in endometrial cancer for its histopathological features, for example, the histology, grade, myometrial invasion, LVSI, lymph nodal status. So all of these clinical histopathological features in endometrial cancers, they are there is a very strong relation of L1-CAM regarding these risk factors of the endometrial cancer with statistically significant odds ratio. So this was another study by Arrow et al. This was included in our meta-analysis. So they showed a significant, the disease-specific survival in L1-CAM positive with the significant p-value. And you can see that there is a huge gap between these two graphs, these two lines of L1-CAM negative patients and L1-CAM positive patients. So this finding is kind of this is very comparable to our meta-analysis findings. Although on the other hand, our meta-analysis finding for MMRD was also very significant, and there is a very poor disease-specific survival for patients L1-CAM positive within MMRD group. And similarly for the P53 abnormal subgroup in the endometrial cancers, the L1-CAM positive has a poor disease-specific survival in our meta-analysis. So these two findings, they are significant in our meta-analysis, but this study showed this is not statistically not significant. So coming towards this is the ESMO recent guideline published in 2022. So this said that L1-CAM is a very significant indicator of high-risk disease, and expression of L1-CAM is the most frequent in p53 abnormal tumors, but also predictive of worse outcome among the tumors with no specific molecular profile. But in our meta-analysis, our meta-analysis showed that this is not only the bad prognostic factor within only p53 abnormal and NSMP, but also for the MMRD. So major guidelines like ESMO, NCCN emphasize molecular classification for risk stratification, while L1-CAM is recognized in the literature as an important prognostic marker, but has not been universally mandated. So the findings of this meta-analysis, it supports that definitely L1-CAM is a promising prognostic marker in endometrial cancer, particularly within MMRD, NSMP, and as we discussed that p53 abnormal subgroup were also at high risk. So this suggests that for those patients with the endometrial cancer for intermediate and low risk cases with NSMP or MMRD, L1-CAM can be used as a rationale to escalate the adjuvant treatment. Why we are talking about this specific poor prognostic marker, that we have to decide our adjuvant treatment on the basis of these high risk features. So this is the NCCN guideline. This is for only the stage 1 disease. So still they are considering like grade as a high risk, like LVSI, age, and so these are some of the high risk features that they are highlighting to escalate the adjuvant therapies for the endometrial cancer patients, but still L1-CAM is not incorporated yet. So this was the POTEC trial that was published. This is a very famous trial for the endometrial cancers. So their 10-year data suggested that substantial LVSI, p53 abnormal, and L1-CAM overexpression were all strongly associated with the higher risk of recurrence for intermediate high risk endometrial cancers. So coming towards the conclusion, so yeah, incorporating L1-CAM testing has the potential to refine the prognostic models as we discussed, just to make sure that we are giving our patients good adjuvant therapy. The other point is that incorporating L1-CAM into the existing molecular and the clinical pathological risk model could refine patient stratification. So definitely we will need some prospective trials and validation of the L1-CAM before incorporating it into the clinical setting. So thank you so much for listening. So I would like to thanks to the Gynec team and special thanks to my co-authors who helped me a lot